Welcome to Going Antiviral, the podcast for the IAS-USA, a professional continuing medical education organization focused on HIV and other viral diseases. I'm Dr. Michael Saag, professor of medicine and infectious diseases at the University of Alabama at Birmingham and volunteer member of the IAS-USA Board of Directors. Welcome to the Going Antiviral podcast. Today, January 31st, 2025, we are speaking to Dr. Andy Pavia, who is the George and Esther Gross Presidential Professor and the Chief of the Division of Pediatric Infectious Diseases at the University of Utah. Dr. Pavia mentors a team of faculty and fellows at the University of Utah and also serves as Director of the Hospital Epidemiology at the Primary Children's Hospital and Associate Director of Antimicrobial Stewardship. His research interests include the epidemiology of influenza and other emerging viral respiratory infections, pneumonia, vaccine-preventable diseases, and emerging infections. Today, Dr. Pavia joins us to provide an update on COVID-19. Andy, welcome back to the podcast.
Mike, thanks for having me. It's great to be back.
Well, you did a great job last time, so I'm looking forward to what we talk about today. And we're going to focus on COVID-19, which is fortunately, on some levels, drifted kind of back into the background. It's not something we're hearing about on the news every day, but it's continuing to be a problem. And so what I'd like to focus on today is where are we right now? And what are we doing? What are the current recommendations about vaccines, treatment, testing, all those things, just to kind of give everybody an update, because patients still come in every day and ask about it. So where do we stand today in terms of new cases and deaths? Let's look back to the year 2024.
So we had a fairly significant year in 2024. We had a winter wave and a summer wave, and the summer wave was actually pretty bad. None of these waves were as bad as what we saw during the pandemic years, but the winter of 23, 24, COVID caused more deaths, more hospitalizations, more illness than influenza did. This year, flu might be giving it a run for its money because we're having a fairly bad flu year. And so far, we're having a winter wave of COVID-19, but it's more muted. I think the take-home message is that COVID's become something that we live with, and every year-round disease, but it's an endemic disease now, not a pandemic disease.
Yeah, so to throw some numbers into that, there were about somewhere between 5 and 8 million cases of COVID. Most of them were managed in the outpatient setting, although there still were maybe up to 200,000 people who had hospitalization. And those are mostly people at higher risk, and we'll talk about that in a minute. And then, as you mentioned, the estimates are somewhere between 15 to 25,000 deaths in 2024, which is obviously not trivial. So why do you think, compared to, let's say, 2021, 22, when you mentioned the pandemic time, where we were seeing maybe up to 2,000 deaths a day at some stages, maybe not that many towards 2022, but why has the number of deaths decreased in your opinion?
Well, first, it's important to remember that the fantastically interesting thing about COVID-19 is how the virus changes, the disease changes, the manifestations have changed. So what we're seeing now, I think most experts would agree, is a disease that is occurring in a background of a population where almost everybody has a moderate to high level of pre-existing immunity. Most people, about 80%, got their first 2 vaccines in 2021. Of course, the rate of people getting revaccinated is kind of disappointing. It's about 30% or a little bit less. And then most people have been infected 1, 2, 3, sometimes 4 or 5 times. So that has created a cumulative level of immunity. The problem with coronaviruses and with COVID-19, SARS-CoV-2 in particular, is that immunity fades, whether it's from vaccine or a single infection or repeated infection. Your protection starts to drop fairly quickly at about 6 months, and there's not too much left over. So in a population that has some antibody, we can still get infected. Some of us, those who are at highest risk, are still getting very sick and even dying. But most people are now experiencing it as a much milder illness and not shedding virus as long and not spreading it as much.
Yeah, so there's 2 points I'd like to highlight with you here. And one is you mentioned that the virus isn't exactly the same as it was in January of 2020. It has mutated. We remember the names now. There's was Alpha, then Delta. Now we're in Omicron, and that seems to have lasted now for a little while, maybe a little over a year and a half or so. And Omicron seems to me to be a little bit more infectious, meaning easier to transmit, but doesn't seem to be as virulent, meaning that it might not be quite as deadly as, let's say, especially the Delta variant. But still, as we said, there are people dying. The other thing I'd like to highlight, and you focused on immunity, is that coronavirus infections we've known our whole lives, a common cold kind of thing or something that comes and goes. And we tend to get that over and over again through our childhood and later in life. And so that contrasts to, say, human papillomavirus, where we have a vaccine. And if a 9 or 10-year-old gets that vaccine, the data show that it's unlikely that they'll even become infected ever with HPV, human papillomavirus. So maybe you can dig in a little bit more to that immunity and what we're looking for if we were to
Mhm.
follow antibodies or cellular immunity.
Yeah. So first, let's talk a little bit about Omicron and its grandchildren and great grandchildren. Omicron, which emerged in I think December 21, caused this enormous wave, and even though the disease was a little bit milder, it caused so many infections that you remember January of 2022. Our hospitals were overwhelmed and people were dying again in large numbers. What's really interesting is that Omicron has continued to evolve, but everything we're seeing today pretty much are variants of Omicron. The current one that's dominant in the US is called XEC. Before that, we had XP2 and XP1. And before that, we had the JN1, 2, and 3. All complicated names, but just to say that we're no longer seeing these complete shifts to a brand new lineage where we went from alpha to delta to Omicron. And with that, the virus is able to escape immunity to much less degrees than it did when it made those big shifts. So the immunity that we have is probably well, we know it's twofold. There is serologic immunity due to neutralizing antibody that's directed at the spike protein predominantly, which is where all the changes are occurring. I think XCC has 37 amino acid changes from older Omicron ones, all of which are designed to help it escape immunity. But then T cell immunity, cell mediated immunity, is probably very important in alleviating severe disease, as it is for many infections. And that is longer lived and is directed often at, themes in the virus, at conserved epitopes. And so most of us are losing our neutralizing antibody at 6 months, so we can get reinfected, but have enough T cell immunity that we're not ending up in the hospital or dead. Now, the one thing that we haven't really talked about is long COVID. And we would have hoped that as we got into our second and third bout of COVID-19 infection, that people wouldn't get long COVID anymore. And certainly the rates have dropped compared to what happened among people who got infected in 2020 and 21. But we're still seeing people get long COVID. And a recent paper came out saying the number of times you're infected is associated with your risk of getting long COVID, which I find kind of scary.
Yeah.
I've had it twice. I'll probably get it a third time. And I'm not very scared of dying of COVID at this point or even ending up in the hospital. But long COVID is a terrible life altering disease.
Yeah, let's dig into that. The definition of long COVID is kind of broad. It's a syndrome of sorts, meaning that it's a constellation of symptoms that could involve the brain, the lungs, the heart, the gut, um, as a rule, and sometimes even a part of the brain, smell, hearing. But mostly the concerning thing is thought processes, and some people have trouble concentrating or headaches, that type of thing. And in the heart, it can be racing heart rates, so-called POTS, where people can just stand up and they get this almost orthostatic tachycardia just walking to their mailboxes. People have been former marathon runners who have trouble just going back and forth to their mailbox. And those symptoms can wax and wane, and the duration of long COVID is variable. It is kind of scary, and I'm with you on that. We don't know why it happens. Do you have any insights on your best guess on why people, especially when you talk about it in the terms of getting repeated infection, um, why long COVID shows up?
So I'm not a long COVID expert, but I did have the privilege of spending some time with Akiko Iwasaki, who is probably one of the great experts who's done phenomenal work in this area. And she gave a great talk, and we had a nice dinner where we talked about it. So long COVID is probably not one disease. The different manifestations you talked about have different genomic signatures in terms of the proteins they express, the changes in the immune system. So the person who has long-standing neurologic disease is not the same as a person who has predominantly fatigue or persistent tachycardia and decreased exercise tolerance. And in each of these, there are changes in the immune system, often immunologic activation, but some researchers have identified 6 different genomic or proteomic expression signatures to define 6 different syndromes. And similarly, using advanced statistical techniques, looking at clusters of symptoms, people seem to fall out into clusters of these different diseases. So it's a very sort of wordy way of saying there isn't one cause. And I forgot to mention probably one of the more prominent ones, which is autoimmunity develops as a
Yeah.
result of long COVID in a subset of people, but that's not present in everybody. So it's really critical that we sort out all of these diseases that come under the heading of long COVID that have in common the fact that they leave people with debilitating symptoms that last years, but physiologically they're different diseases or different syndromes, and they probably will have different treatments. Although we've got a long way to go before we have good treatments for most people.
And I think that explains the conundrum that the docs fall into when they diagnose a case of long COVID. What do you do? Some people have thrown steroids at it. Well, in some people it helps a little bit, and a lot of people it doesn't do anything. And it fits to your great description of the pathobiology. And there are lots of studies going on. The biggest one is this RECOVER trial that the NIH is sponsoring that has a lot of these small trials all clustered together to look at different ways of approaching treatment that are more syndromic, meaning that it's either neurologic or
Yeah.
POTS or that type of thing. But it's mostly symptomatic coverage, and so that's not as satisfying in terms of helping to guide us. It's a challenging problem to figure out.
You can, yeah, it's very challenging. You can imagine that as we sort it out, we can target treatment. So some people have evidence of persistent virus. Those patients may benefit from longer courses of Paxlovid, although the first study was kind of disappointing, or vaccination to improve their immune response to it. People with autoimmunity may benefit from focused immunosuppression aimed at those autoantibodies, similar to the way we would treat lupus or other autoimmune diseases. Patients with cardiac dysfunction may require yet a different type of treatment. So it's going to take a lot of basic science to know how to design the trials and a lot of clinical trials. And I feel really badly for the patients who are suffering with it because it's taking a long time. And we don't have a lot to offer today other than to say we're unraveling the science, which will let us develop treatments. But, if that means another 6 or 8 months before you could even enroll in a trial that might help you.
But I think what we've just been talking about underscores the requirement for all of us with any new disease to understand the pathology, the pathobiology. And as you just laid out nicely, that's going to be different perhaps for every one of the types of syndrome collection that we encounter, so that if we cluster everyone together who has quote unquote long COVID, it's not a surprise that when you just apply, for example, a longer course of antiviral therapy, like with Paxlovid, you might see a small subgroup that gets better because maybe the virus is persisting there, but for others that doesn't apply. So when you look at the big population, you don't see an effect. And so we got to be real careful to parse the entry requirement for a lot of these studies based on the
Yeah.
pathobiology or what we understand.
And I think we have to be careful, as clinicians, we want to treat the patient in front of us with something, but we have to be mindful that when we don't know what we're doing, and some of the tools at our disposal, be they steroids or immunosuppressants, or even long courses of Paxlovid with its bad taste and drug interactions, potentially could do more harm than good. So we're in that frustrating position of wanting to do something, but not knowing what will really help other than graded exercise and treating the sleep disorders and the depression and being, acknowledging that it's a real disease and being sympathetic and keeping an eye out for treatments that can help those patients.
Circling back now to vaccine, there have been a couple studies that have shown that serial vaccinations are somewhat protective against long COVID. Have you bought
Yeah.
into that? Yeah.
Well, I think the data are pretty convincing if you look at the um, the cumulative evidence from a variety of trials, and there's been a systematic analysis. Not every trial has shown protection against long COVID, or every study, but the majority have, and so it's a pretty consistent, moderate level of protection. I think most of the point estimates hover around a 50% reduction in your risk of getting long COVID. To me, that's enough reason to keep up to date on my vaccines,
Yeah.
regardless of how I feel about getting another bout of COVID.
So who should be vaccinated in 2025?
Well, CDC recommends that everyone should be up to date on their vaccine, and that means having gotten the updated vaccine that came out this fall. I think that when you make those kinds of recommendations, it's hard to get the subtlety into it and still have a recommendation that everyone can read. If you're a healthy 25-year-old who's been up to date on every vaccine and has had COVID twice, the benefit of getting a vaccine is relatively modest. Now, the benefit probably still outweighs the risk, but there's not that much in it. But if you're an older person, if you're relatively non-immune because you've not had COVID before and you haven't had a vaccine in a year or two, you have a lot of benefit for it. So that's the blanket recommendation to everyone. But the strong recommendation I would make is that older people, and it's actually a continuum. The risk goes up at 50,
Mhm.
and then at 60, and then at 70. So it's not a cutoff where you cross one birthday and you're suddenly at really high risk. So older people, people with immunosuppression, people with underlying conditions, particularly heart and lung conditions, definitely want to keep up to date on their vaccine. So the older, the more important it is, the more immunosuppressed, the more important it is. This year, CDC came out with a recommendation that because the protection from the vaccine fades over time, and it fades more quickly in older people, they recommended that people over 65 and those with immunosuppressing conditions get a second vaccine of the 24-25 version. So that would mean if you got vaccinated in September, that you should be looking to get another vaccine in January or February. I don't think too many people are actually doing that, but it's really worth thinking about for our most vulnerable patients.
So let's transition now. We mentioned possible use of Paxlovid or other medicines for treatment or prevention of not prevention, but treatment of long COVID. What about who are the people that you're going to pull the trigger on for, say, something like Paxlovid, or when you might refer somebody to a infusion center to get a couple, 3 days of remdesivir?
Well, I think with Paxlovid, which is an oral drug, obviously, and in spite of the bad taste and the occasional GI upset, is a pretty safe drug if you can avoid the more severe drug-drug interactions or moderate them. I think the decision to use it, in my mind, is relatively easy. People over 60, people with any immunosuppressing condition, people with heart and lung disease, including bad asthma that requires multiple controller medications, not the person who wheezes once a year when they get a bad cold, um, should be treated when they become infected. And of course, we know that, like with most viral diseases, the earlier you start treatment, the better. So I think it's really important for us as docs to have educate our at-risk patients to have a treatment plan. You know, if you're talking to your 40-year-old patient with HIV whose T cells are still in the 200s, say, you start to get a cough, sore throat, bad cold, take a COVID test. And if it's positive, call me and do it on day 1 and repeat it on day 2, or do it on day 2 and repeat it on day 3, and we'll treat you. Now, of course, with HIV patients, the drug-drug interactions can be a little tougher, although not as bad as they used to be. Um, and certainly true for the elderly and transplant patients and others who are at high risk.
Yeah, I think that's really important. And in today's world, like literally right now, we're at the end of January 25, where we have, as you mentioned, not only COVID kind of lurking, but this flu outbreak, as well as maybe some RSV and other things. It feels kind of we should be educating, especially those at risk for more severe disease that you've outlined, so they as soon as they get some early symptoms, the home test is fine, but we're going to have to distinguish between COVID and flu and some other things. Just go to an urgent care center, your doctor's office, whoever has active um, respiratory panel access to sort of find out exactly what it is. Because if it's not COVID and let's say it's flu, the same rules apply to earlier treatment, right? That you want to get
Yeah,
people on in the
absolutely.
first 24 hours if possible.
Well, as you know, I'm sort of a flu guy, so pushing high risk patients to get antiviral treatment in the first 48 hours, ideally, is really important. And there's been a big change in the last couple months, which is the first 2 home flu COVID tests are on the market. I haven't bought any, I haven't tried them, but their sensitivity is not perfect, so a negative test doesn't rule everything out. But for a lot of people, particularly if you don't have good insurance coverage, a good first step might be a $20 home test rather than a $200. And I don't know if $200 will even cover a visit to an urgent care center these days.
Right.
But getting tested, and if you still think the negative test may be wrong, getting retested with a better test is really important for high risk patients.
So I think a take-home point for the uh, healthcare providers listening in is for those who are at pretty high risk for something bad with either flu or COVID, have a conversation with them before the seasons hit and say, vaccination, really important. But if you start developing symptoms, come in and we'll get you tested as soon as your symptoms are really starting to emerge, especially if you've been around someone who's been diagnosed with flu or COVID. Come in early so that we can get you on treatment early. What are you doing for referring people to, like, say, an infusion center for remdesivir? I've been doing that for people who are on um, monoclonal antibody therapy with rituximab and that type of thing because they tend to not respond quite as well to Paxlovid, and a 3 to 5 day outpatient course of remdesivir
Mm.
seems to nip it in the bud. Are are you subscribing to that kind of approach as well?
Yeah, it's with decreased need for remdesivir infusions, it's harder to get a bed in an infusion center, and so it's become a little more difficult. But I think for the most at-risk patients who have a contraindication to Paxlovid, those are the folks that I would try and treat. And a subgroup that's really important there are transplant patients, because some of the immunosuppressive drugs that they're on can't simply be stopped for a week and have a major drug-drug interaction with Paxlovid. I mean, if you're on a statin, it's really easy. You just don't take your statin for 5 days and then 2 days after you take it, and that's fine. Nothing's going to happen if you miss your statin for a couple of days. But if you stop your tacrolimus for 5 or 6 days, that's a big deal.
It's a big deal.
Or if you take it with the ritonavir component and you get toxic on it, you could end up on dialysis. That's happened to a couple patients at our center.
Yeah. Um, our time, as I knew, is rapidly running out, but I did want to touch on 2 other issues. One is this Pemgarda, which is the only remaining monoclonal antibody that we had. Back in the day, we used the bamlanivimab or the other
Yeah.
drugs. Now, this is the only one that's active against the Omicron. So those prior ones that were great no longer are effective against Omicron. But Pemgarda, which is a trade name, is effective as prevention. Who are you recommending that treatment for? And it's given every 3 to 6 months IV.
Yeah, it's so it's active against the currently circulating XEC and the previous children of Omicron, and it's our only option for patients who cannot make their own antibody, ever lost all their own antibody. I think that's really the target group. So patients who've had a allogenic stem cell transplant, patients who are on B cell active drugs that have completely wiped out their antibody and so have no pre-existing immunity and can't respond to vaccines. Those are the patients I think we should be using it on. Our transplant and oncology colleagues, adopted the earlier prophylactic monoclonals much more so than they are doing with Pemgarda. I think because they don't perceive the risk as much, because they're not as geared up to do it. We're probably underusing it. I don't think we need to be using it on everybody who's at increased risk, but there is that subset that have no other means of protection.
So, final thoughts. We've covered a lot of material, and I think you've done just a great job of synthesizing where we are today. Um, any future therapies you're excited about? Any predictions for 2025?
Well, I'd love to see a non-ritonavir requiring antiviral. And of course, the studies need to be done that really give us the patient-centered answers we need now, which is how long are you going to be sick? How long will you be out of work? Are you going to infect your family members? And there's at least two candidates that may make it through that may do that. And so, assuming they're not terribly expensive, they'll be really nice tools to have in our tool set. The other thing that I think all of us really want is next generation COVID vaccines. We want vaccines that not only prevent hospitalization and death, but have longer acting protection against infection and shedding. And that probably means mucosal vaccines. That's, where most of the research is heading. And we want vaccines that don't have to be retooled every year or twice a year to keep up with mutations in the spike protein. So it's very similar to what we need for influenza vaccines. We need longer acting, broadly active vaccines for COVID. And ideally, the sort of the dream would be a vaccine that would protect you not only against SARS-CoV-2, the current coronavirus that is killing people, but all the other coronaviruses out there that have the potential to jump to humans.
Well, I'm going to try to summarize, but I'd like maybe for us to do this together so I don't miss anything. But what I'm hearing is COVID is still out there, it's still with us. It still causes significant morbidity and hospitalization among those at highest risk and death. Um, Maybe up to 25,000 people in the United States a year dying from COVID. The vaccine is effective. It's especially effective at preventing hospitalization and death for those at risk. But there's some hints that it might be reducing long COVID as well. So another reason that we might be a little bit more uh, proactive in getting some of the folks who maybe don't perceive themselves so much at risk, but at least maybe to get an annual vaccine, that the treatments are actually quite good, but we're looking for better treatments that don't have drug-drug interactions, and that our population of patients at highest risk, perhaps we should have conversations with them before flu season, before COVID, so that we can have them come in at the first onset of symptoms to get tested, know what we're dealing with, and get them on the appropriate antivirals. What else would you add to that?
I think that's a beautiful summary, Mike. I think this is very similar to flu in a way in that the tools we have aren't perfect. So if you only have 50 or 60% protection from the current vaccines, that's obviously suboptimal. But when many of us are going to be listening to this in their car and you're wearing your seatbelt, and your seatbelt saves 40 or 50,000 lives a year, but it's not what we really want. We want a roll cage and curtain airbags and be wearing a Nomex suit, you know, but we still put on our seatbelt, even though it's not perfect. And our vaccines and even our antiviral drugs aren't perfect, but they're pretty darn good, and we should take advantage of them.
Wonderful, wonderful podcast, Andy. Thank you for joining us. Great as always. We look forward to bringing you back at some point to talk about other respiratory viral diseases or other perhaps outbreaks. But thank you for being with us. Great job.
Thanks, Mike, and thanks for this podcast. It's a great podcast you do.
Thank you. Thank you for listening to this episode of Going Antiviral. Catch up on earlier episodes wherever you listen to podcasts, and check out the video versions of this episode and others on the IAS-USA YouTube channel. You can find these links in the show notes, or simply go to YouTube and search for IAS-USA, and there they are. Be sure to subscribe, rate, and review Going Antiviral on Apple Podcasts. This podcast is for informational and educational purposes only and is not intended to serve as medical advice. Opinions expressed in this podcast do not necessarily reflect the opinions of the IAS-USA or its affiliates. If you have a question you'd like answered on the show, you can send it to podcast@iasusa.org to be answered in a future episode.